So, okay. So Dr. Kate J. Wilks is a family medicine physician and an active member of the ACCP and the current statewide medical director for Centurion Health in Idaho. She participates with us in correctional medicine grand rounds. She has a real deep interest and passion about nutrition, obesity, and weight loss, common issues in American society. And this is one of her primary care roles in the correctional medicine setting. Dr. Wilks will share her practical expertise and knowledge about the challenges and rewards of working with our incarcerated patients on healthy lifestyle, and particularly weight loss in our practice setting. We really hope you enjoy this session, and we look forward to hearing your discussion with us today, Kate. So I give the microphone to you, and we look forward to your presentation.
Okay, wonderful. So I really want this to be we'll go ahead and move forward. Let me just move a couple things. Okay, there we go. I think I can see everything now. So I really want this to be a practical approach for our patients because as we'll talk about, I mean, weight is such a challenge for patients. It's such a sensitive topic. And so I really want to kind of focus on things that we can help our patients do in their lives to make a difference and help them meet their goals. So the first part is, why are we talking about obesity? So to put it really blankly, obesity tends to make people feel bad. They don't want to get up and move around. They just feel kind of blah. And probably the bigger reason from our standpoint is it's a risk factor for other diseases. And a big one that comes up in our setting is the liver disease. So it's actually not NASH anymore, it's MASH, metabolic disordered associated steatohepatitis. And we see so many patients with chronic liver disease, and it's just aggravated by their weight. So you can see all the different organ systems that can be impacted by a patient's weight. So why me? So I'm going to share 3 parts of my personal life to kind of give you a sense of why I feel so passionate about this and what my experience has been. So I'm going to start off with my mom. So my mom went to law school when I was in middle school. She gained much of her weight at that point during law school. And so here I was a teenager and watching my mom gain this weight, and then the difficulty that it put her in, and then challenges with losing that weight. And interesting enough, she got a knee replacement, a hip replacement. If I had $1 for every time my patients told me, well, just give me a new hip, Dr. Wilks, I'll lose weight. So she didn't lose weight with either of those. But she got the diagnosis of prediabetes, and that motivated her to work on a low carb diet. And then she actually lost much of the weight. So you can see kind of this one is the most recent picture. Next, I'd like to share my experience with my children. So as you can see there in the picture that they probably qualify for class 2 obesity. My youngest is actually very physically active. He's an offensive lineman, so his size gives him an advantage there. And so I have struggled as a parent that how much do I want to push my children to lose weight or try to get like a normal BMI, and what impact that will have on them and their healthy eating practices the rest of their life. Finally, my personal journey with weight. So you can see the years there that I put that either I had a major weight gain and weight loss, and then pregnancy. Obviously, it's good to gain weight during pregnancy, but it definitely kind of impacts our healing and metabolism. And then in 2019 is when I actually got into exercise. I participated in a suicide awareness 5K. I had volunteered the first year, and then I was like, I could do this. So my goal was to actually run in it the next year. And so since then, I've been able to maintain that exercise and have done fairly well with maintaining my weight since then. So this is my journey, and I've seen my loved ones deal with it and how hard it can be, and have experienced that myself personally. So it is hard. So the benefits of weight loss, even something as small as 5 to 10%. So if a patient is 200 pounds, 5% is 20, sorry, 10% is 20 pounds, 5% is 10 pounds. We can see improvement in their blood pressure, prevention of diabetes, improvement of that liver disease. Heartburn is one that I always like to bring up. And as you'll see, some of our commissary examples, our patients tend to experience a lot of heartburn. So even just that 10% weight loss can really make a difference, not having that abdominal pressure on their stomach. And you'll see, I do have a list of all the website references at the end, but I put QR codes on each of the slides so that you can have a quick access to where those pictures came from. What does weight mean? So again, with talking about goals, with that as our focus, I use the example with my patients. Not every patient with high cholesterol has a heart attack, but we give them statins, not necessarily to bring down their cholesterol, but to prevent that heart attack. And does every obese patient have diabetes? No. Like I remember back in residency, I had a patient who his BMI was like, it was like 35 or 40, and I was like, he's got to have diabetes, right? Well, no, he didn't have diabetes. His A1C, I think, was like 5.4. So when we're evaluating a patient with their weight, it's important to take a history, talk to them about what weight changes they have had in the past. If they keep going up and down, now may not be the best time for them to start on their weight loss journey. What diets have they tried in the past? Any comorbid medical conditions, what physical activity are they able to participate in? So those are all important things to ask them about what they're currently doing and have done in the past. It's also important to review their medications. There's multiple medications that can tend to push on the side of kind of gaining weight. Although one physician I worked with, formerly Amish guy, said that medications don't make patients gain weight. They may make eating more makes you gain weight. I always add the comment that they can make you feel more hungry, so you want to eat more. But I feel like that is a good awareness for us to keep in mind, that medications can't necessarily make you gain weight just by taking a pill. Labs, remember that there's other causes of obesity like thyroid disease, Cushing's, and then also checking for comorbid conditions, like checking their cholesterol, checking them for diabetes. And that can help motivate them to, again, start or maintain their weight loss journey. But in general, just reminding patients, this is a huge risk factor for disease. And so something that we want to actively address. So some ways that we can monitor weight. So the BMI obviously is really popular. Very fairly easy to measure. I do want to talk a little bit about the weight to height chart ratio. So this is one that some people are moving a little bit more towards, for a couple of reasons. One is the acknowledgement of the abdominal obesity tends to have a little bit more impact on comorbid conditions. And it's a little bit easier to track. And this is an example where if we could get our patients like a measuring tape for their abdomen, this is something that they can check on a daily basis and look for changes and use that as real-time biofeedback outcomes. I know nursing, so patients always tell me, well, Dr. Wilks, the scale is always broken if there is even a scale. And then nursing is like, Dr. Wilks, you can't tell them to just walk up to medical and ask to check their weight. Like that's really disruptive. So the weight to height ratio might be a good option. And then just to point out, so the average for US females and males already puts us at a loss of 1 to 2 years of height of life. And one thing that I often ask my patients is, how long do you want to live and what do you want that to look like? I remember going to Oregon fresh out of residency from West Virginia and just amazed at how little obesity and how active my patients were, like into their 90s and late 90s. And that was not necessarily something we had in West Virginia. I also do want to talk about the BMI. Again, it has its shortcomings. It's not perfect. But two things. One is, so you can see whites here, ethnicity, we probably should be interpreting BMI based on ethnicity. So here we see the 30 BMI, and that's considered obese. But if you look at Blacks, or South Asians, really that risk factor for diabetes goes up dramatically at a much higher or a much lower BMI. And so for South Asians, maybe we should be getting a little bit more worried, a little bit more aggressive when their BMI gets closer to 24. And that's something that fortunately for us in corrections, it's a little bit easier for us, I feel like, to say, well, this is their goal BMI, and this is what we're going to, this is where we want them to be. Whereas in the free world with insurance companies love to put numbers on things. And so, put numbers on things and so push to, well, everyone has to have a BMI between 20 and 25. So the other point I want to make about the BMI is so morbid obesity is really an outdated term. We really should not be using it. The current classification is class 1 through 3 obesity, and that is based on their BMI measurement. So next slide. So why is it so hard, right? So consistency, behavioral change, food addiction. Do we eat to live or do we live to eat? Maladaptive learning. All of these things contribute to why it is so hard to lose or maintain our weight. Specifically in corrections, patients have access to commissary. Sometimes it feels like their life revolves around commissary or canteen. Limited options for personal dietary preference. Some of my most difficult patients were chefs out in the outside the wall, and they kind of expect the kitchen to live up to their standard for food. Cultural foods. I know here in Idaho, we have a large population of American Indians, and trying to be sensitive to those cultural habits. Boredom, smoking cessation. So taking smoking out of prisons was probably one of the best things we ever did for people's health. But it has been shown over and over again that when people stop smoking, they tend to gain weight. Sleep, it's hard to sleep in prison, and lack of sleep, poor sleep definitely has an association with weight, increased weight. Again, access to a scale, trying to get them, there's a couple of studies that showed that being able to weigh yourself on a daily basis can help with weight loss and maintain that weight, just because of that real-time feedback. Difficult access to bariatric surgery. So I think this is one thing that's going to be a big change in the next 5 to 10 years in corrections. And you'll see some of the data later on in the presentation about weight loss surgery, bariatric surgery. One of the pros, though, is our patients don't have a financial barrier to contribute to non-adherence. So in the obesity CME that I went through, One of the whole lectures was about non-compliance and non-adherence, and there is a difference between the two. But our patients don't have to worry about changes in copays or medication access. So that is a pro that we have. So this is a really busy slide. I included it to illustrate how difficult it is. So you see here in the center the energy balance. It can be impacted by individual psychology, social psychology, food production, food consumption, physical activity in the environment, physiology. So what this means to me is we really need to have empathy for our patients, compassion for our patients for what a difficult task we are asking them to do. And also, I really try to get my patients to focus on things that they can control. Obviously, no one can go back and change their breastfeeding status when they were an infant. But there are some, we can change our physical activity. We can change the calories that we're taking in. And then I wanted to just kind of hone in on the physiological factors. So I know many drug companies are trying to focus on like leptin supplementation, impacting like thermatogenesis and impacting different levels of this so they can make a magic pill. I'm guessing if they were successful, we would have better options on the market. And so again, it's hard even from a physiologic standpoint, but again, really trying to get the patients to focus on things that they can control. So interesting thing I learned about is that apparently children are supposed to, around 4 years of age, are supposed to dip down in their BMI and then go back up. If they don't have that dip, it increases their risk for obesity for the rest of their life. So yeah, there's a lot of factors that are beyond our control. So a little bit of audience engagement. So go ahead and go off of mute or put it in the chat. What do you think this patient's chief complaint is?
Everyone, I'm going to try to unmute you. Kate is asking for your active participation with this question. Now I'll unmute all of you guys.
Okay.
I was going to say shortness of breath.
Shortness of breath. Okay.
Mobility.
Mobility. Yeah, he's in a wheelchair. He's in a hospital setting. Okay. A small gown. Okay.
Yeah, I saw the mobility issue as well. Difficulty walking.
Okay. Perfect. So our next slide, what would you guess that this patient's chief complaint is?
In the safest way. You could say for a really long time. If people go out of their way.
Do you think it's knee pain?
She wants to know whether she has a normal weight. What is she normal? She looks like a teenager or a young person. So she wants to know how she compares with everyone else.
Yeah.
Language.
Yeah. So even though it's in Spanish, you can still tell that this is about weight and levels of obesity. What else do you guys? Oh, inability to lose weight or can't gain weight. So this is a really important segue into weight bias. So on our first patient, we were talking about shortness of breath, knee pain, things that most are mobility issues that probably had that we're thinking and don't try to pretend that you weren't, because studies have shown that bias is very real. Things that are probably related to his weight, like secondary complaints of his weight. In the other picture, we had a patient with a normal BMI. And so we were thinking about things that probably didn't have to do with her weight. So weight bias is a very real thing that we need to make sure that we're sensitive to. So, and some of the things that contribute to it is this cultural belief that people are responsible for their weight, thinking that stigma and shame will motivate patients to lose weight, which doesn't work, just like it doesn't work with substance use or smoking. Cultural belief that values thinness. So this is a fairly relative thing. If you look through history, there's periods where overweight is valued or thinness is valued. Blaming the victim rather than acknowledging those environmental conditions. Like we showed with that huge thought map, all of those things are contributing to it. And so just trying to keep that in mind. So how I manage my patients and try to address weight bias is asking permission. And I think it's really corny to be like, hey, can we talk about your weight? So I usually say things like, how do you feel about your weight? What is your goal weight? And so getting a sense of do they even care? And interesting enough, again, in the outside the fence world, insurance companies are really pushing this idea of weight and BMI to the point that like some of the other family practice docs were telling me at the conference that if a patient comes in for ear pain, they have to check a BMI and they have to document that they talk to the patient about their weight. So I don't think any of us would really appreciate being counseled on our weight if we're coming in for an acute ear infection. So it's just really being pushed out there and not always in a very sensitive way. Another way that we can address weight bias is using a symptom-based treatment goals and not a number-based. So rather than saying, hey, I want you to get to a BMI of 24, let's lose weight until your knee pain gets better, until your back pain gets better, rather than shooting for a specific number goal. Understanding the stages of change model and motivational interviewing. Not every patient is ready to start their weight loss journey. And so, so it's not particularly helpful to try to force that. So, so I put a picture there of the stages of change. And so many of our patients in the pre-contemplation mode. So I leave the door open. I say, hey, when you're worried about your weight and you want to talk about it, let's talk about it. So, and then just moving through, so the patients in the stages 2 and 3, those patients are ones that we can really work with. We can really help to start on that journey. So, okay, so disordered eating. Again, like I said, when dealing with my, and I have to admit, I'm kind of glad that I have boys and not girls. So there's many ways of disordered eating. And unfortunately, as healthcare providers, we tend to reinforce disordered eating because we have patients who are coming in, we're counseling them about their weight. And then when they lose weight, we're congratulating them and celebrating it, but not necessarily asking, well, did you do that in a healthy way? And so it's important to be aware of the screening tools for disordered eating and the screening tool and keep that in mind. And again, when we celebrate the weight loss with our patients, always kind of get a sense of, well, how did you do that? I was talking with our PT yesterday about patients on Ozempic, and so they lose muscle mass along with fat mass. And so a lot of musculoskeletal issues were coming out with their weight loss because they just they weren't eating protein. They were on low calorie diets, weren't eating proteins, and they were losing that muscle mass. I thought this was a really fascinating slide. It's actually through the New York Times. I don't think it was ever really published in a formal medical journal. But looking at patients that were part of the Biggest Loser competition, and we have several years of data now. So this was looking at the 6-year point. So again, it's fairly old, but the results I think were pretty dramatic. So it showed that obviously some of the patients regained weight. Many of them regained and even someone above their pre weight. But the patients that were part of the Biggest Loser, their metabolism slowed down worse than it was 6 years ago. So even at 6 years,
Alex,
had a decrease.
over 18.
Suzanne, I think there's someone that needs to go on mute.
Pakiroll mo kaya, ano kyan, Dad?
So even at 6 years,
Okay.
so he was losing or burning 800 fewer calories per day than expected. That's like 2 cheeseburgers. Okay, so that's a lot. And then also the slide, the graph isn't included, but they found that these patients had a leptin deficiency. So leptin helps us feel full so that we can stop eating. And these patients, it dropped when they started to lose weight and then it stayed low. So they're feeling hungry more. So what this means to me is let's wait until the patient is ready. So again, we avoid that yo-yo effect. So the overall plan, we obviously want an energy deficit. Hopefully the patient won't feel like they're completely starving. Behavioral changes, and sustainable changes. So long-term follow-up, self-monitoring. This is a lifelong journey. Cognitive restructuring, problem solving, goal setting, maintenance. So those are the important things to prepare our patients for. So again, one more look into my personal life. So this is my sister. She has always struggled with her weight since she was a child. But she is probably the healthiest person that I know. She is very physically active. She is the healthiest eater I think I have ever met. She used to participate in a farming co-op and would embrace the weirdest vegetables, some that I've never even heard of, just embrace those and really get to them to integrate them into her diet. Like that, things that would just end up rotting at my house, she was eating on a regular basis. So again, remembering that a normal BMI is not necessarily a great goal for all of our patients. So I thought this was really interesting because it looked at some of the top 10 tips for weight loss, and it quantified what kind of calorie deficit we could expect to see. So keeping to your meal routine actually doesn't really help with that calorie deficit, and so is not necessarily going to help our patients move towards that weight loss goal. Walking, so this is one of the areas where the 10,000 steps came in. Reducing fat, packing a healthy snack. You can see what calorie deficit those are expected to produce. One thing I want to mention about the snack is that's if you snack. If you don't snack, then it's probably not a good idea to add a snack. And so sometimes when we're working with our patients, it's important to start with what they're doing now. So like, for example, I went to a family medicine conference, and so I went to a couple lectures about food science and talking about probiotics and prebiotics. And I tried kefir, I think it's kefir milk. So there's great foods out there that we can add to our diet that are healthy, but what are they going to replace? We don't necessarily want to just add calories to what the patient is already eating. Couple more. So nutritional labels. This is a kind of hard thing with Chow Hall with our pre-prepared meals, is knowing what those food labels are. Proportions, I'm sure everyone's familiar with the smaller plate size. Standing up every hour is not only good for our musculoskeletal system, but can also be good for our weight. Any juices, especially for children, juices are not helpful. And so water, plain coffee are things that are going to be preferable. Focus on your food, slow down, eat, enjoy your food. Don't eat while watching TV or playing on your phone. And again, not really a significant calorie deficit, but it again just helps us have kind of that overall healthier eating pattern. 5 per day. So they're trying to get this changed to 5 vegetables and fruit. Which doesn't seem like much of a difference, but when you say fruit and vegetables, people are like, oh, great, I got my 5 servings of fruit. The fruits have a lot of simple carbohydrates, and so probably do not have quite as much benefit as vegetables. So sorry, you need to eat your broccoli and cauliflower over your grapes and oranges. So this can get you to about 800 to 900 calorie deficit per day. The initial recommendations for kind of a weight loss diet is to get at least 500 calories less per day. And that can help contribute to about 1 pound of weight loss per week. So macronutrients, I encourage my patients not to get too complicated. And so carbohydrates have 4 kcals per gram, protein 4 kcals per gram. Fat is up to 9, so that's why fat is very calorie dense. Alcohol, so again, most of our patients don't have access to alcohol, which is a great thing because, I mean, you're almost up in the fat range as far as calories. So first slide about talking about diet. So a very low calorie diet or low calorie diet, it works, but it's hard. So protein is very important. Like I mentioned earlier, we need to be cognizant that weight loss is through all of our muscle, or I mean our body, all of our body tissues, not just fat tissue. The calorie goal for a low calorie diet is about 1,000 to 1,500 calories per day. Very low calorie diet is about 600 to 900 kcals per day. And this is pretty restrictive, like you're going to be hungry. The very low calorie diet is not recommended for more than 12 weeks. So that is a very short term process. We see it a lot like in the medically supervised weight loss clinic, bariatric clinics, and typically is done through a meal replacement process. So patients basically pay a certain fee and they are sent pretty much everything that they can eat for that day. A lot of companies will do it in shakes because those tend to be pretty shelf stable and able to ship out. The low calorie diet can be used for long term. I mean, one thing I like about this is the simplicity. Okay, so as we talk about some of the other diets, I mean, trying to educate our patients, well, you can only have 30% of your calories from fat. And especially in our setting where they go to chow hall and they're not necessarily getting a nutritional label, can be really challenging. The diagram here, so if we do, so the EI stands for energy intake, EE stands for energy expenditure. And so you can see as soon as we drop on that energy intake, that desire to eat is going to go up because the leptin is suppressed. And that energy expenditure is also going to go down and may or may not ever get back to the baseline. So these are the challenges with this diet. Now, if you have a patient who has class 3 obesity and you're trying to get them to a bariatric surgery or trying to get their back pain improved, these risks may be worth it. So again, kind of focusing on that goal and just a reminder about SMART goals. So they need to be specific, measurable, attainable, realistic, time bound. So expecting someone to go from class 3 obesity to a normal BMI in a couple months is really unrealistic and probably harmful. So really trying to work with the patients and come up with those, what their goals are. Class 3 obesity really probably needs a dietitian involved. We're luckily here in Idaho, we have an amazing dietitian that works at the statewide level. And just the balance between that's when you really have to kind of worry about your micronutrients and protein levels in order for patients to safely lose weight. And that's another kind of reason, like with the very low calorie diet, why they have those meal replacement services, so that again, they can make sure to adjust those macro and micronutrients to the patient's needs. So additional diets. So like I said, it kind of gets more and more complicated from there. I put the web link and a QR code here, so you can just access this chart yourself. Some of the more common ones are high protein, Mediterranean, ketoacidosis. I know my friend did keto for a while, and I guess pickles are really good for ketoacidosis. I don't know, I got her whole basket of pickles for her birthday present. So low fat diet. So that's going to be like your Jenny Craig and Weight Watchers diet. Intermittent fasting probably is actually more related to overall calorie restriction rather than the actual fasting component. So that's basically where people only eat for a certain part of the day, or they basically fast or don't have any food intake anywhere from usually 12 to 16 hours per day. 5-and-2 diet. This is actually something I had never heard about before, but it came up at the conference the family medicine conference I went to a couple weeks ago. So this is the 5-and-2 diet has actually been shown to reverse diabetes. So basically for 5 days, and again, I like it because of the simplicity. So for 5 days, they basically eat whatever they typically would do. 2 days, they limit their intake to only 500 calories per day. So again, they're going to be hungry on those 2 days. But the simplicity, and if they kind of meal plan and they're like, okay, this is all I'm going to eat on my 2 500 calorie days, it can be really easy. And once you've ate that much, then you're done for the day. So there's one more slide about the different diets. So here's a breakdown for the Mediterranean. The Mediterranean is actually more kind of a way of eating and kind of a focus on different food groups. So again, that probably is the most, when we talk about healthy and like decreasing cardiac risk, those sorts of things, the Mediterranean diet is probably the best, but it's kind of confusing. And for our patients, it would be really difficult to coordinate that with chow hall and what they have available on commissary. So, okay, so the next thing, kind of segueing into our anti-obesity medications that can cause weight gain. So we are having a really hard time with neuropathic pain in Idaho. And this is one thing that I bring up with patients is gabapentin contributes to weight gain, tends to contribute to weight gains. And so you can see the average impact they have here, which I will point out for most medications is not really dramatic. I mean, 3 to 4 pounds. So amitriptyline, that's one thing our patients complain about. We're using a lot of Tegretol and Priluptil, which also can contribute to weight gain. Although amazingly, my patients talk about so much weight gain with Priluptil, with Tegretol and Priluptil, but no weight gain with gabapentin, which doesn't really make sense. Our antipsychotics obviously get a big bad rep for weight gain and metabolic syndrome. Insulin actually is weight promoting. So the way I think about it is rather than getting rid of that glucose, the glucose stays in your bloodstream and it gets absorbed into the fat cells. Beta blockers also tend to contribute to weight gain. Prednisone, hopefully they're not using that long term, but it can. And so really trying to look at these alternatives. I know some of these aren't very popular in corrections, like bupropion or Topamax, but maybe we need to reconsider that bias, considering the challenges our patients are having with weight. I also always like to kind of go back to the history of weight loss medications. So, no, I remember Orlistat. Can you guys maybe raise hands, or like, do you guys remember Orlistat? Most of the people I know about like have never even heard of it. I talked to a guy today who was like 29. He's like, yeah, Dr. Orlistat, I've never even heard of it because it made everybody poop grease. Like, I still remember the Orlistat potato chips, and they thought it was going to be revolutionary. And here, like less than 2 decades later, no one's even heard of it. Phentermine topiramate came out in FDA approved in 2012. That actually is probably a pretty good medication for weight loss. The Qsimri specifically does have an indication for long-term use. The phentermine only medications are were only FDA approved for short-term use, and we'll talk a little bit more about them. But then bupropion naltrexone, so another one that nobody really thinks about. But I've always kind of liked it because I mean I feel like overeating has a lot of overlap with addiction, so food addiction. And then obviously the one everybody wants to talk about is our GLP-1 receptor agonists. And the first one, the liraglutide, was approved in 2014. So some of the GLPs have been around for almost a decade. But you can see the more recent ones really have not been around very long. So okay, so then mechanism of action. Again, I really like this summary because it helped me kind of put the different medications in different boxes. So centrally acting medications, we have the appetite suppressants, the naltrexone, bupropion, the phentermine, topiramate. The GLP-1 receptor agonists work in the gut. And then again, nobody wants to talk about Orlistat, but that also works in the gut. So again, the QR code will take you directly to the article with this table. But so the GLP-1s, again, everybody wants to talk about. So the thing, so I feel like I have a healthy mistrust of big pharma. Maybe not as much as some providers. I know my sister in medical school was like one of those anti-pen people. But I feel like I have a healthy mistrust, and I think one thing that one of the lectures I went to brought up is, so these drug company studies for the GLP-1 they had very intensive lifestyle interventions. So these patients that were taking these medications were not just taking these medications. They had nutritional counseling, they had exercise. Like, I don't know if it was to the point of like a personal trainer, but again, not necessarily just our patient off the street who's like, hey, I just want to take a med and not do anything else. So I think we need to keep that in mind when we're looking at these potential weight loss numbers. On the other hand, I do want to, again, try to be fair. The GLP medications have been shown to help significantly with other comorbid conditions. So say, for example, for me, I'm about 10 to 15 pounds above where I like to be, but I don't have any comorbid conditions. So I'm not going to go to my doctor and ask for Ozempic, even though it could help me get that extra 10 to 15 pounds off. So again, just a reminder that these studies are probably a bit optimistic because those patients had pretty intensive lifestyle monitoring or changes. But but they may be really helpful for patients with comorbid conditions. And it's interesting. Again, my healthy mistrust of big pharma. It's interesting how they're trying to kind of co-market them for other conditions. One of the lectures I went to specifically on GLP at the conference, the lecturer talked about her experience and her husband's experience. So she was doing lifestyle changes, wasn't meeting her goals, went to her doctor, started on Ozempic, lost about 65 pounds, and then tapered off of it. So that was something new that I had heard, is the idea of tapering off of the medication rather than just stopping it cold turkey. And she actually maintained most of her weight loss. Her husband started seeing her lose weight and was like, hey, I want to lose weight too. So I want to take the Ozempic. So he took it, didn't make any lifestyle changes, lost about half as much of weight. Deciding, I don't know, he was tired of taking it, whatever, stopped it cold turkey and ended up gaining back most of his weight. So just kind of some real life examples for you. Okay, so then again, I would just reference this chart. But again, the phentermine topiramate is actually, again, it's been around for a while. It's cheap. And it's been shown to have pretty effective 10% of the body weight, not too shabby for medications. The second to last slide I have on medications is the number needed to treat. So as I've been trying to integrate evidence-based practice here into my practice, I really kind of focused on this number needed to treat idea. So for the QSIMRI, so if we treat 3 patients, at least one of them will reach that 5% weight loss goal, which is pretty good. And then looking at adverse effects for discontinuation is not that bad, whereas you can see it's higher for the GLP medications, and I have a feeling that's gonna we don't know the full impact of where that's gonna be. With the weight loss medications, it is important to make sure that you know your state laws. I went to medical school in Ohio, and then I came back later and practiced in the outpatient clinic and didn't realize that Ohio has very specific rules that I will say have recently changed in 2023 about prescribing weight loss medications. So be aware, make sure that you're aware of what the limitations are in your state. Surgery. So just a quick summary of the different types of surgeries. Wanted to point out 2 things. So Roux-en-Y gastric bypass. So a lot of our patients come in having had these surgeries. Really is only for BMIs over 50. And those patients need vitamin supplementation for the rest of their life. So when patients are coming into our system, we should be asking about surgeries. And if they've had the surgery, we do need to provide vitamin supplementation. Same thing for the duodenal switch. So looking at the data, so I really like this slide because it combined a lot of different things. So like meal replacement, pharmacotherapy, GLPs, bariatric surgeries. So again, I'm not sure our hesitation on doing this in corrections, doing bariatric surgery in corrections is entirely warranted if we really want to combat this system. The obesity. The other thing I like to point out is look at the years of data we have on the bariatric surgery. So this one is specifies 10 years. The medications, the other ones, we just don't have that long-term data to understand what effects that they're going to have. So I just wanted to give an example. So everybody talks about exercise. So exercise is great for many reasons. Unfortunately, it doesn't contribute a lot to weight loss. So I have a picture here of, like I said, I started exercising in 2019. This is one of my workouts. I ran for 35 minutes. I burned almost 500 calories. So this is what we're looking at. So I could have a McDonald's Big Mac, a plain bagel with cream cheese, couple candy bars, but that exercise we usually are not going to be able to outrun our calorie intake. So corrections. So the last about 10 minutes of the presentation, I want to talk specifically about corrections. So chow hall, so the challenges that our kitchens face. So the diets must accommodate a wide variety of health and fitness levels. So on the previous picture, I had a picture of a young, healthy guy, and then an older gentleman that looked like he was in hospice. So they have very different nutritional needs. Oftentimes they're contracted out for a for-profit vendor. Incarcerated individuals prepare the meals. So patients that may have only a third grade education are trying to manage these complex allergies, special diets, those things, food allergies. I could probably spend 20 minutes just talking about food allergies, but basically our patients seem to have a lot of them. Renal diet, pre-dialysis and dialysis diet. So a lot of our patients are in Idaho are trying to get the dialysis diet because it has some extra protein, but it's not really appropriate. We need to be using the diets for what they're meant for. So this is the breakdown for Idaho. And like I said, we have a really amazing dietitian here. And so you can see our main line has almost 3,000 calories per day, which is a lot of calories. Our healthy choice, which is not a carb restricted diet, but a carb consistent. Again, if our diabetics are consistently eating the same amount of carbs, we should be able to dose their insulin to cover that amount of carbs. So this is the one that we typically recommend our cardiac patients, our diabetic patients to use, but it's still 2,000 calories per day, which can be a lot. Diabetic snacks, 300 calories per day. So if we're giving patients 3 diabetic snacks a day, that's an extra 1,200 calories. I think I did my math right. 1,200 calories per day. And really with the newer insulins, the diabetic snack is really obsolete. Patients shouldn't be going up and down so much. So I've worked in prison in 3 different states, and every prison I go to, the patients always complain about the food. I would really encourage you to actually go to your kitchen and see what they're eating. So these are examples of some of the trays here in Idaho. So I just want to point out, like, there's a fresh salad. You can see here there's vegetables that have been cooked, but they look like vegetables. The bread is it's not 100% whole grain, but it's a partial like whole grain mix. Again, I encourage you to go to your kitchen, see what the patients are actually eating. I've never actually seen I've heard that there's boxes that said food not for human consumption. I've never actually seen it, so I don't think it's really happening. But go to the kitchen, look at the trays, find out what is actually being served. Okay, so commissary. So we did a field trip to commissary. I kind of divided up things into 3 different categories. I'm sure we could have discussion about which category I chose all night. A couple things I wanted to highlight. So this is beef. So there's, it's processed, but it's protein, peanut butter, red beans and rice. So if you combine beans and rice, you get a complete animal protein. So vegetarians and vegans, that's how they get their appropriate amino acids, by combining plant proteins in order to get those complete. So some more good chicken breast, fish sticks in soybean oil, pasta sauce, dry milk, coffee. Again, plain coffee is not necessarily an awful drink. It's better than some of the juices. Okay, so commissary. So talking about commissary would not be complete without ramen. So this ramen is just such a mainstay. I was talking with a patient today that how many more options could we add to our commissary if we could just get rid of the ramen. So our commissary vendor says, hey, we can't add anything unless we take something away because we physically do not have space. So you can see the amount of ramen and then the boxes behind. So again, and I put less good on purpose because I try not to demonize foods. So again, you can see pickles for your keto patients. Chili, I like to point out again the heartburn issues, refried beans, again without that complementary rice to get a complete plant protein, not really as healthy. Less good, again, sharp cheddar cheese, probably a good source of protein, but maybe a bit processed. Jalapenos, spicy Thai chili sauce, things that are really going to contribute to heartburn. Okay, so the ugly. So these are one of my favorites, the peanut butter wafer like cookie things. I love those. Vanilla cookie, or no, these are strawberry cream cookies, honey buns. There's probably actually a cookbook out there on managing honey buns. The turkey stick. So just looking at it, you think like, hey, maybe this is a pretty good option. But if you look at down here under added sugars, there's 8 grams of sugar. There's only 11 grams of protein. And so again, really trying to make the calories that you're taking in count. I'm not sure turkey stick with honey and brown sugar is going to be a great option. Milk chocolate, cappuccino mixes, probably not a great option on getting our patients to their goal. Cajun mix, fruit flavorings, gravy, pasta, things that aren't really going to add much to their overall nutrition. Spam, I wasn't really quite sure where to put the spam. I feel like I need to eat spam at some point so I can understand it. I don't think I've had it since I was a kid. And unexpected. So talking about seasoning and flavorings, these are some of the things that are available on the religious menu, but could be used to add some seasoning and flavoring to the foods. So apps and podcasts and websites. So Weight Loss for Busy Physician is one of my favorites. Noom app, that's actually one that we got for my son that he did okay with. Nutritionprescriptions.com. I would really recommend checking that one out. They actually have some handouts about glycemic index and diabetes, blood pressure, cholesterol, nutritional, and they're available in Spanish. And then if you guys want to put in the chat what your favorites are and what you recommend for patients, obviously our patients can't access them directly, but we could always try to advocate like, hey, JPay, I don't know if I'm allowed to say that, but our tablet companies like, hey, maybe we should be getting apps for like mental health or meditation or for weight counseling. So the summary, check height and weight, consider adding waist circumference to your vital signs. Be sensitive to weight bias. Ask permission before we dive into a discussion with our patients. Multifaceted approach. Don't just do medications. Don't just do surgery. We really need to look at all those, as many areas that we can control as possible. SMART goals. There is no perfect diet. Really consistently, again, have the patient do whichever diet they can maintain. Focus on clinical goals and not just a number. Take the fear out of feeling hungry. Like you're going to feel hungry, and that is not dangerous. The medications, again, I am kind of cautious about using those in my practice. Surgery really has the best long-term data especially for that class 3, like that severe obesity. Exercise is never a bad answer, just as most people just can't outrun what they eat. Corrections, work with your dietitian. They may not have one for every facility, but I think part of NCCHC is that At least every state has a dietitian. Check the patient's commissary purchases. Unfortunately, here in Idaho, it's really difficult to access that. And so it's not one that I've been able to counsel my patients with in like real time. But if you have access to that, print it out, show them, be like, hey, this is really hurting your chances to getting to your goal. Visit the kitchen and just remind our patients this is a lifelong goal, a lifelong journey. My final, I'm just going to put in a little blurb for if you are a board member of the AAFP, I am trying to put together a members interest group for corrections. I know the ACCP is really working on the AMA and getting a seat at the table for the AMA. This is kind of similar for family medicine specifically. So if you're a family medicine AFP member, please let me know. So we have to get at least 50 people on the application in order to get that member interest group pushed through. The QR code on the right is to get my contact information. And I apologize, I went right up to time. But again, it's just such a, we just have such a great opportunity to make a difference for our patients by actively addressing this. Don't hide from talking about it. So this is my last slide. So we will go ahead and open it up for questions. I have been kind of keeping an eye on the chats, and I don't think I missed any. I saw Dr. Niki mention we are what we eat, and yeah, a national movement to improve the quality of food in the incarcerated population. I think that would be great. It's just hard. It's expensive. So feel free to jump off of mute and ask a question or comment.
Well, thank you so much. I want to thank you for the beautiful presentation you put together. This was really eye-opening, and I know each state has its own program for the like feeding, and that probably feeding the incarcerated population probably is the least priority for our administrators at this point. So even I feel like even the food that they are putting in front of them on a daily basis are majority basically processed food and canned food that are mixed up, and we really need to change that culture.
Yeah.
Yeah,
I
it's
saw
very,
other people come off and mute.
yeah, I'm sorry. Okay, can you hear me now?
Yep.
All right. Okay, I was going to comment that it's very difficult. I'm trying to get the camera off. In a correctional setting to try to control your diet, particularly even if you are able to get the nutritionist to have a nutritional diet, the commissary is often the culprit. And I wonder if you've had any success or thought about a patient education project, not just for those that may be overweight, but for all the patients. Just maybe put a sign up or a post up to say, you know, how to read a label. And these are the healthier snacks. This honey bun has fewer fat calories than that brand of honey bun, something like that, to try to encourage people to take control of their own diet as much as they can.
Yeah. We are a couple of things. So we are working on in Idaho getting the nutritional labels on the tablets for Chow Hall. Obviously, for any of the commissary, it does have nutritional labels on the back. And I don't know, maybe even having kind of a poster with like better options, less like I presented. I do really try not to demonize food. I have a huge sweet tooth. I use the example of my dad, and you guys have almost pretty much met my entire family. But my dad with weight loss is he will eat an entire like banana cream pie, but that's all he eats. It drives my mom crazy, but he maintains his weight because he doesn't eat dinner and the banana cream pie. So I really try not to demonize foods because then I would be a big hypocrite. And you work with the juveniles, and it's really hard with the juveniles because again, I mean, their nutritional needs are very different than our
Yes.
elders.
Yes, that it helps a lot though because we have complete control of the diet. We have no commissary.
Yeah, yeah,
So we're able to provide the meals and all the snacks that are approved by the registered dietitian. And then we don't serve coffee or tea, to get milk, water. So it's a little bit easier because we are able to control all of the really everything that they get, even when they have like special parties or something for behavior, then we get the dietitian involved and make sure it's a healthy choice for the snacks.
yeah,
Uh, Dr. Wilks?
yeah,
Yes. So there was a good presentation, by the way. So there was something I wanted to mention, but I guess the feature is not included in this presentation. So when you mentioned like behaviors such as like addictive behaviors that maybe contribute to weight gain, I also wanted to bring light, and you can always correct me, because I'm still wet behind the ears. Also maybe trauma that
yeah,
contributes to their behavior. So like maybe when this is a correction facility, so we have to consider maybe their traumatic childhood or even adulthood experiences where maybe food was kept from them,
yeah,
kept from inmates, or you know if they experience abuse, child abuse, where um, they had a really small window to eat food, or else they would go hungry, or like foster care. I don't want to downplay it, but um, those things also I feel they may contribute to their behaviors. Um,
yeah.
so
Well, and
it's something to
I
think
grew up
about.
with the clean plate diet, so I feel like that's a very like middle class Midwestern attitude that you didn't leave the table until your plate was clean. Like it didn't matter if you were full. So I think even like I think there's a lot of reasons for us to have disordered eating patterns into adulthood. So yeah, definitely. And I guess I just try to get my patients to focus on things that they can control. I mean, we can't necessarily control our history, but just try to face up to it and do what we try to change those behaviors. But no, totally. And I guess that's one thing that I haven't really looked into is just I would love to do group visits with our patients, but again, kind of trying to pull our clinicians in to help with kind of that disordered eating and counseling and changing those patterns. So, and it's funny, like the Clean Plate Club, I mean, I clean my kids' plates too. Like I'm like, oh, everybody's plate has to be clean. We can't throw away any food. And I'm like, no, 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 don't do that, Dr. Wilkes.
And also, just a quick mention along the same lines with trauma. Sometimes people also eat to self-soothe. It's,
Mhm.
eating good food, particularly for those of us like myself that love food, is really comforting and can be somewhat therapeutic when you don't have any other source of how to feel good.
Yeah. Yeah, no, I'm gonna add that if I do this presentation again, I'm gonna definitely add a slide so I can more intentionally touch on that. Thank you.
Could you comment on how accessible your patients' access is to a dietitian in
Yeah,
those
so in
institutions?
Ohio, it was awesome. We had Airmark, but part of the contract with Airmark was that a dietitian had to meet with every diabetic every year. In Indiana, we had Airmark, but that was not the case. Airmark just had to provide a dietitian for, and actually, I think we shared her with other states. Idaho, they have not really contracted out the food program. And so Idaho DOC employs a dietitian that does the diet for the entire state. I mean, we're a relatively small state. But for me, she's been super accessible. I mean, it's not really her job to do like direct patient care or counseling, but the couple patients like with that class 3 obesity that they're ready, they're at that part in their journey to really try to lose weight she has been helpful to try to come up with a diet. So not super accessible like directly to the patients, but I have found her to be very accessible.
I think the new ADA guideline that they put out will help us request that for like diabetes and because each patient is unique. They want to do carb count versus calorie limitation, so that's an interesting part.
Yeah. No, carb counting would be nice. And Idaho had a very, they used to be all based on Excel spreadsheets, but then they've upgraded the system. I think it was last year. So now they can like interchange. I feel for the dietitians. So I started out as a dietitian major in undergrad. I feel for them because they're very stringent guidelines that they have to follow. And so like our previous dietitian I was talking to, she's like, well, Dr. Wilks, I can't just take this and like substitute it for that. Like it has to have like really similar nutritional qualities in order to substitute it. But they've told me with this newer system, it's much easier to kind of interchange thing. And they actually go out to, there's like wholesale sales for like food. And so they'll get like overstock food and stuff, and then they can plug it in. Like I said, I've been very impressed with the diet in Idaho, like considering other states.
Well, and a lot of our patients that have been incarcerated out of state, when they come back into Idaho, we've had a lot return from Arizona recently who have indicated that they're really happy with the diet now that they've been incarcerated out of state.
Yeah, they see what it's like. And if anyone can get a picture of a box in the kitchen that says not for human consumption, that would be my highest priority for advocacy.
There is no box in the kitchen to that effect. I went and looked myself because I've heard that all the time. So I told them to show it to me.
Yeah.
And they couldn't.
Great. Well, like I said, I realized we kind of went over time. But if anybody, I guess actually, if I could solicit some feedback on maybe other states about bariatric surgery and your experience with getting it approved. If anyone's willing to kind of unmute and speak up about that process, I would love to hear it. I really think I mean, if you look at the data, we're already getting pressure to use GLP meds, but the data really is in the bariatric surgery realm. And then I just want to thank you guys for listening. I don't do a lot of public speaking, so I was a bit nervous. But thank you guys all for coming and listening, and I'll hand it back to Susan.
Thank you, Kate. This is such a lovely presentation. Obesity is a true American concern, both in the free world and in the incarcerated world. And as these GLP-1 agonists is becoming super popular, and it's been a real trailblazer with weight loss. So in light of Kate's question, bariatric surgery statistics in incarcerated settings, feel free to reach out to her. Feel free to reach out to ACCP. Any other questions before we close it for the night? Okay. Well then, thank you so much, Kate. I wish you all a good evening and we'll see each other soon. Take care.
Thanks. Great job.